Now the treatment of asthma. We have to know the goal of the treatments, which is decrease symptoms, day or nighttime symptoms, restore the normal or near normal as possible the lung functions, decrease the exacerbation of asthma, frequency of exacerbation. For children, enable the normal growth of children, decrease the need for rescue medication, reach the normal PEF values, and no unwanted side effect of the used medication. Before starting the treatment of asthma, you have to know the rules of management. All doctors, pharmacists, nurse, and patients have to know the following. Reduce exposure to trigger factor may help to improve asthma control. Successful management of asthma need a partnership between the patient and healthcare provider. There is aim to give the patient the ability to control their asthma by supporting the guided self-management. This point is very important. Individualize the action plans for each patient. Improve the health outcome, especially in the moderate to severe disease, and also increase use of reliever medication. It's may warning uh, mark for deterioration of asthma control. Assessment of asthma control is very important to deciding how steps that the patient reach and deciding to step up or step down of the treatment. At each treatment review, inhaler technique and adherence to a treatment should be checked. Some of patients use the non-right way of inhaler, and there is no benefit of use of inhaler. The main treatment of exacerbation of asthma include repeated beta-2 agonist and early use of corticosteroid and oxygen to raise the PaO2 more than 92%. After exacerbation, also patients should be reviewed early and identify possible triggers and review the plan needed. For chronic asthma, there are four major classifications of asthma severity. The intermittent, which is the simplest one, in which patient present with symptoms less than 2 days per week, and nighttime waking less than 2 times per month. Short-acting beta-agonist use less than 2 times per week and no interfere with the normal activity. FEV1 between exacerbation with FEV1 predicted راح تكون more than 80%, and the percent of FEV1 over FVC is more than 85%. While in mild persistence, the symptoms is more than 2 days per week, but not daily, maybe intermittent. Nighttime waking from 1 to 4 times per month, and short-acting use, beta-agonist use is more than 2 days per week, but also maybe not daily. Minor limitation in normal activity, FEV1 predicted type, which is maybe more than 80, and the ratio more than 80 also. Moderate persistence, there is a daily symptoms, there is a nighttime waking 3 to 4 times per month, or more than 1 week per month, but maybe also not nightly, not subsequent nightly. Depending on the age, daily use of the short-acting beta-agonist increased, some limitation in normal activity, and FEV1 between 60 to 80%, and the ratio between 75 to 80%. And lastly, in the severe persistence case of asthma, symptoms is present throughout the day. Nighttime waking more than 1 week per month. Short-acting beta-agonist used several times per day, and there is an extremely limited normal activity. FEV1 decreased to less than 60, and the ratio less than 75. Now we have to know the rules of the treatments, the guidelines of the treatments, which is depends on the severity of asthma. Treatment divided into steps from 1 to 6. Step 1, which is the mild intermittent asthma. Step 2, regular preventer therapy. Step 3 needs add-on therapy, and step 4 also add-on with combination. Step 5 persistence, poor control, and the last one, step 6, with continuous or frequent use of oral steroids. This figure can summarize the 6 steps of treatment. Step 1, which is start by short-acting beta agonist on needed. Step 2, low dose of inhaler corticosteroids, and there is an alternative by chromoline long leukotriene receptor antagonist and another treatment. Step 3, the preferred is the low dose inhaler corticosteroids in addition to long acting beta agonist or medium dose of inhaler corticosteroid. The alternative is the low dose inhaler corticosteroids plus either leukotriene receptor antagonist or thiophanine or xylotine. Step 4, preferred medium dose inhaler corticosteroid in addition to long-acting beta agonist. But if the symptoms persist, we can use the alternative, which is medium dose inhaler corticosteroid plus either leukotriene receptor antagonist or thiophanine or xylotone. Step 5, preferred to start increase the dose of inhaler corticosteroid in addition to LABA, and consider omalizumab for patients who have allergies. Step 6, prefer the high dose, keep the high dose of inhaler corticosteroid in addition to LABA and starting oral corticosteroids. And maybe your patient need to consider omalizumab for patients who have allergies. We can step up or step down according to the situation of the patients. Drug treatments. The stepwise treatment of asthma based on 3 principles. First of one is the asthma self-management with regular asthma monitoring by using the peak flow meter for each patient. Also, the appreciation that asthma is an inflammatory disease, so we need to use the anti-inflammatory, which is the controller or preventer, which is should be started even in mild cases. Also, the use of short-acting inhaled bronchodilator like salbutamol and terbutaline only used to relieve the breakthrough symptoms during attacks, so that patient should have to know if there is an increased use of bronchodilator treatments to relieve the symptoms is an indication of deteriorating the disease. The mainstay of asthma therapy is the use of therapeutic agents delivered as aerosol or powders directly into the lung. Why it's preferred to use the inhaled drugs? Because of it's delivered direct to the lung, we can avoid the first pass metabolism, and we need the lower dose, and so that there is less systemic unwanted effects. Inhaled oral steroids, inhaled short-acting reliever, salbutamol, terbutaline, inhaled long-active reliever and disease controller, which is LABA, long-acting beta agonist like salmeterol or formoterol, in addition to sodium chromoglycate, and leukotriene modifiers like montelukast, zafirlukast, pranlukast, and xylotone. Other agents with bronchodilator activity is the antimuscarinic agent, ipratropium bromide, oral oxytropium. Theophylline preparations also used. Steroid-sparing agents like immunosuppressive agents, which can be tried to decrease or regulate the steroid use for patients who cannot tolerate the doses of steroids, like methotrexate, cyclosporine, gold, and anti-IgE monoclonal antibody. Mainly the used one is the omalizumab. Reliever medication. The mainstay of asthma management is the short-acting beta agonist bronchodilator, SABA, which is the first-line agent in the management of asthma. Each buff can power 200 microgram. This may be only the treatment necessary for those with frequent symptoms, but in some cases, we need to add another bronchodilator. We can choose ipratropium bromide. It's one of the anticholinergic agents, but it has slower onset of action than SABA, but with longer duration of action. Also, the benefit of using anticholinergic is obvious in patients with a degree of obstructive airways disease. The long-acting beta-agonist bronchodilator, LABA, also is indicated when the low-dose inhaled steroid failed to control asthma. So it's indicated instead of increasing the steroid dose. Each patient starting LABA should be assessed or monitored after 4 to 6 weeks of using to see the LABA has been effective or not, and whether further treatment needed to be added or existing treatment is enough or should be changed. It's advised that LABA should only be added if regular use of standard dose inhaler corticosteroids fail to control asthma adequately. Also, it should not be initiated in patients with rapidly deteriorating asthma and should be introduced at low dose, and the effect properly should be monitored before considered to increase the dose. Should be discontinued if there is absence of benefit, if there is no benefit, and should be reviewed as appropriate. Stepping down therapy should be considered when the good long-term asthma control have been achieved. Some patients need combination of inhaler corticosteroid and LABA, like formoterol and budesonide combination inhaler, which is nowadays is widely used. These combinations show there is that this dosing method is an alternative in step 3 for adults who who poorly controlled on SABA and ICS separately, who have experienced one or more severe exacerbation in the previous year, or as an use as an alternative to increase the ICS dose to above 2 milligram per day at step 4, and this mainly lead to more side effect of oral bronchodilators also may be added. Thiophanate as oral could be added at step 3 or 4, or beta agonist oral tablet at step 4. Usually, slow release form should be used twice daily, or there is another type or another preparation can be used as a single dose at night time if there is nocturnal symptoms. Thiophanate should be started at dose of 4 to 500 mg per day in adults and may be required to be increased after 7 days to 1 gram per day. In children, high doses may be required, but this will be determined by the age of the children. Why? It's homework. I need your comments about these statements. Thiophanate, as you know, has a narrow therapeutic index, and its hepatic metabolism varies greatly between individuals. Thiophanate clearance affected by a variety of factors, including disease status and concurrent drug. In some patients, high doses of beta agonist may be required. In this type of patient, we can use the nebulizer. We can use salbutamol dose of 2.5 to 5 milligram per dose by nebulizer. Also, terbutaline has been given by continuous subcutaneous infusion in the maintenance treatment of difficult to treat asthma. Preventor medication include anti-inflammatory drugs, and mainly it's the inhaled corticosteroids. It's used when the patient who are not controlled by SABA alone. Inhaled corticosteroids are the initial drug of choice. The starting dose of beclomethasone or budesonide is 400 microgram per day in divided dose. Which patients should consider inhaled corticosteroids? Patients with exacerbation of asthma in the past 2 years, patients using inhaler beta agonist 3 times a week or more, which is, as I mentioned, indication of deterioration of symptoms. Patients with symptoms 3 times a week or more, and patients when symptoms interfere with the sleep or waking one night per. If the symptom persists, we can increase or stepwise the dose of corticosteroid according to the severity of the case. The inhaled corticosteroids also should be reduced if possible when there is a symptoms relief or improved and the PEF rates improved or the patient stabilized. If the patient's asthma cannot be controlled, the dose could be increased to 1.5 to 2 milligram per day. As you know, each increase of dose associated with increase of side effects. So all inhaled corticosteroids have dose-related side effects. For example, adrenal suppression occurs at around dose of 1.5 milligram of beclomethasone in adults, while in children the dose should be 400 microgram per day of beclomethasone or more according to the case, which are maybe associated with growth failure and adrenal suppression. Another inhaled bronchodilator could be used as sodium chromoglycate and lidocaryl sodium, but it's less effective than corticosteroid in asthma. Even so, it's a possible alternative if corticosteroid cannot be tolerated. Another drug is the leukotriene receptor antagonist. The main used members is the montelukast and zaberlukast. Leukotriene receptor antagonist introduced in the guidelines of treatment in step 4 as add-on therapy, but still the addition of leukotriene to inhaled corticosteroid is less effective than the addition of LABA to inhaled corticosteroids. If the patient started this drug, it should be monitored after 4 to 6 weeks to evaluate the effectiveness of this drug. If there is no improvement, the drug should be stopped. But some study reveals that leukotriene have a particular value in aspirin-induced asthma. Omalizumab, which is the anti-IgE monoclonal antibody, it's indicated for severe persistent IgE-mediated asthma as add-on therapy. Also, it's indicated only for patients over 12 years of age who have severe unstable disease. Patient response should be assessed or measured, and omalizumab treatment should be stopped after 16 weeks if there is no adequate response seen. When the symptoms of asthma cannot be controlled with the maximum dose of inhaled bronchodilator and steroids, now oral corticosteroid should be added at step 5. To decrease the side effect of oral corticosteroids, this drug should be given as a single morning dose to minimize the adrenal suppression, or by using alternative day dosing to reduce the side effect. But this method is less effective in controlling asthma. Another method is a short course use of high dose oral steroid, 40 to 50 milligram daily, which can be safely used during exacerbation of asthma. In another in another way, to decrease the side effect of steroid in patients who need high doses of steroid, we can use steroid sparing agent like immunosuppressive agents, which can be tried in an attempt to reduce the regular steroid dose. These include methotrexate, cyclosporine, and gold. These drugs have tried with varying success. All of these drugs have potentially side effects and need to be closely monitored. For treatment of acute severe asthma, which is a life-threatening condition of asthmatic patients, immediate treatment should take place at home if it's moderate attacks, and patient should be admitted to hospital if there is PEF less than 50% of predicted or normal, or if the patient cannot complete sentence in one breath or is too breathless to talk, or if life-threatening features are present. At hospital, the treatment protocol of severe asthma include the following. Oxygen should be administered to achieve the oxygen saturation of 92% or more. Another notes, it's possible to achieve oxygen saturation of 99 or 100% It is another homework for you. I need your comments. Also, beta 2 agonist is administered with high doses. High doses maybe need nebulizer, starting with MDI spacer attachments, starting with 4 puffs, then 2 puffs every 2 minutes until to reach the maximum dose, which is 10 milligram, or symptoms relief. Nebulizer indicated or used because they permitted a high dose, about 10 to 20 times the dose of MDI. Patients undergoing an acute attack also need nebulizer. Why? Because inspiratory rate that's too low to use the MDI effectively. Corticosteroid is also needed to be given in the acute attack, starting with oral prednisolone 40 to 50 milligram daily for 5 days. If the patient cannot tolerate the oral corticosteroid, intravenous hydrocortisone 100 milligram vial should be required. This can reduce and prevent the inflammation that cause edema and hypersecretion of the mucus, and that's why help to relieve the resultant smooth muscle spasm. If any of the life-threatening features are present, like cyanosis, bradycardia, confusion, exhaustion, or unconsciousness, we need a high dose of bronchodilator. Nebulized salbutamol 5 mg with ipratropium bromide 0.5 mg, which is repeated after 15 minutes to reach the continuous nebulization of salbutamol at 5 to 10 mg per hour. Intravenous aminophylline, which is life-saving drug in this situation, can be given with a bolus dose of 250 mg over half an hour, followed by continuous infusion of 0.5 mg per kg per hour. If the patient's known to take oral theophylline or aminophylline before attacks, the bolus dose should be omitted. The choice between the aminophylline, intravenous aminophylline, or beta 2 agonist depends on the other drug used, concurrent therapy, and the side effect profile of the drug. The dose of intravenous aminophylline use must take into account the recent theophylline therapy in addition to other factors. As you know, theophylline is one of the drugs that have low therapeutic index. In addition, magnesium sulfate may be indicated as IV infusion, 1.2 to 2 gram for 20 minutes. If there is an evidence of bacterial infection, antibiotic may be indicated. After that, we have to assess the patients. As the patient responds to treatment, infusion can be stopped and other treatment changed or tailed off as prescribed above. Also, as improvement continues, we can stop the nebulizer use of beta 2 agonist and return to the inhaled beta 2 agonist. Also stopped or reduce the oral corticosteroid to the maintenance dose if clinically necessary. As a clinical pharmacist, you have to know the importance of patient care and patient education, especially for a disease like asthma. There are 3 main steps in the education of asthmatic patient. The patient should have an understanding the action of each of the medicine they use. The patient should know what is asthma, what is the drug used, how the drug used for this type of disease. Also, the appropriate choice of inhaler device should be made, and the patient should be educated to use them correctly. It's very important points. In addition, individualize the action of treatment, which is called self-management plan, should be developed for each patient. Thank you.